Okay, so today we're going to go over chapter 21, and that has to do with clients who have orthopedic injuries and rehabilitation concerns. So it's going to give us a general framework so we can meet the needs of those clients. Today we're going to talk about some injuries, some phases of tissue healing, and some orthopedic concerns that we should just be aware of. Some common terms that we're just going to throw at you is microtrauma. So that means overuse. And if microtrauma doesn't sound like an overuse situation to you, think about micro tears in tendons and ligaments because that's what's happening there. With a macro trauma, that's going to be a sudden onset. A subluxation is going to be a partial dislocation, and a luxation would be a full dislocation. So just remember sub, like submax, will be partial. Next is a strain. So that's going to be an injury to a tendon or a muscle. And then a sprain is an injury to a ligament. So I just remembered that by remembering that strain has the word train in it, and you train your muscles. So there you go. The next term that we're going to go over is contusion, and that's just a fancy way to say bruise, or there's some bruising. Bursitis. So we actually have a sac called our bursa sac, and that's going to be located around our joints. And bursitis is an inflammation of that bursa. Tendinitis is inflammation of a tendon. And osteoarthritis and osteochondrosis seem very similar. There's literally like one word that's different in their definition, so just be aware of that. Let's go ahead and talk about the tissue healing process. And at the very end, whoopsies, there's a nice little graph or picture that kind of ties it in together. So let's just talk about the first phase, and that's going to be the inflammation phase. That's the shortest phase, a couple days, and tissue is regenerating and forming during this phase. And we're going to use the common acronym RICE, which is ever evolving, of course, not the acronym itself, but yeah, we'll just save that for later. Okay, so RICE means rest, ice, compression, and elevation. And we have to stress to our clients that rest is going to maximize the natural healing process. The next phase is just a little bit longer. It can last up to 7 to 21 days, and that's going to be the repair phase or the proliferation phase. So this is when the tissues are being replaced with scars. Wow, you guys. Okay, that's when the tissues are being replaced with scar tissues, and we can begin to introduce low load stresses to our clients. The last phase of tissue healing is remodeling. So that's about 2 to 4 months to a whole year, and that's when the weakened tissue is going to get stronger and we can start to add activity-specific exercises. So we're hoping for a full restoration of tissue function following injury. So here's that picture I was talking about. I use pictures like this as a study tool. So what I would do is like draw 3 empty circles that connect to each other, draw the little timeline underneath, and just, even if you don't know all of it right now, just go ahead and fill it in as much as you can, and then double check with a picture, and eventually you'll be able to fill out the graph or draw the graph just by yourself. And I don't know, I think that's a helpful study tip. But moving right along, these are some goals that we have through each of those phases. So remember, that first phase is really short. For inflammation, our only goal is we want to control pain. So we can't always control pain, but we can control what we do. We can limit painful situations. And then we want to also limit inflammation. For the repair phase or the proliferation phase, we just want to make sure that our goal is increasing range of motion and flexibility, helping with balance, proprioception, neuromuscular control, and then strengthening. And then in that very last phase, we want to maintain our range of motion, and we pretty much have similar goals to proliferation, except we have added 2 new ones, which are functional strengthening and returning to activity. Okay, so we're going to talk about a couple orthopedic concerns. We have to remember that as trainers, we are not certified or responsible to determine movement restrictions or limitations, but we should be able to determine appropriate exercise strategies based off the limitations that are given to us. Some things that we can look out for while we're training clients with these orthopedic concerns are going to range from seeing how their range of motion is, seeing if they have warmth in certain areas, their color is changing, flexibility, and things like that. And we just have to remember that last bullet point is just saying educate your clients and support them through their recovery. So a couple other terms that we're going to talk about. Indication and contraindication are opposite of each other. So indication is a good activity that can benefit your client, and a contraindication is an activity that is prohibited due to the given injury, something that we would want to avoid, something that if you do, you can be liable for. So contraindication, those are things that if we prescribe to our clients, they can get us in trouble, and even worse, hurt your client. A precaution is just something that can be an activity that can be performed under supervision according to what we're given as limitations. So we're going to talk about some guidelines if you have a client who has low back pain, and that's probably something that you will run into. It doesn't mean your client is injured. People who have sedentary jobs or who are beginning to start their fitness journey and don't know how to brace their core, use their core correctly, they can have low back pain too. So all different types of people can be affected by this. If you look at 1 through 6, it's going to say avoid, avoid, avoid. And a lot of that says unsupported spinal flexion. So what we can do is make sure that our client is supported with their spine. That would be a great thing to do, right? We want to maintain strength and flexibility of the abdominals as well as the hamstrings and the hip flexors. We want to maintain a neutral spine whenever possible. So finding a neutral spine is pretty simple, and it's kind of fun to teach to your client. Maybe we can post a video with a visual about that later. So just use these guidelines 1 through 12 if you have a client who experiences low back pain. One thing I found with my personal clients is if you maybe begin the session with a little bit of core where their back is supported, and then you finish the session where their back is supported and you're doing more core exercises, and then maybe giving them like a low back twist or a gentle stretch for their back, they're going to love it, and their posture and the way that they move about their day is going to improve. But just remind your clients the stronger their core, the less their lumbar has to take, really, if they can engage their core and pull it on in. So we're going to discuss a lot of injuries right now. So let's just get right into it. Lumbar injuries, the 3 that we're going to talk about are lumbar disc injury, muscle strain, remember what that is, and then spondylolysis. Oh, geez. Okay, so spondylolysis and spondylolisthesis. So just bear with me on that one, okay, you guys? Look at this picture if you have a moment, because it's going to show you the nucleus pulposus, and I think that's very important for this next slide that we're going to talk about. Cool, so lumbar disc injuries that can happen is a herniation. So this picture kind of just depicts it really well. A herniation is when the nucleus pulposus, that's a gelatinous inner layer, when it makes its way through the outer annulus fibrosis, causing inflammation and aggravating the nerve roots. So it's actually touching the spinal nerves. That's a herniation. And they can cause an increase in lower extremity pain. They're affecting the nerves, right? Abnormal sensations and weakness. And then remember that a muscle strain is a tear to a muscle fiber, and we definitely just want to avoid exercises that are going to aggravate that pain any further. So we're going to dive into this next slide. Please forgive me if I pronounce these wrong, but we're going to talk about spondylolysis and spondylolisthesis. The first one is going to be a defect or fracture of the pars interarticularis region of a lumbar vertebra. So if you don't know where that region is, Look at this picture to the bottom right and it'll make so much sense. So it's just a fancy schmancy word, okay? And then spondylolisthesis, I hope that's the right way, you guys. That's going to be the possible progression of the aforementioned condition, and what that is a forward slippage of a vertebral body over another. So causes can vary, but it commonly occurs in people who participate in activities that constantly require lumbar extension, like divers and football linemen. So some things that we would want to do with a disc injury, an indication: passive lumbar extension stretches, isometric abdominal and extensor strengthening, and then eventually progress to lumbar stabilization. Two things that we want to stay away from when someone has a disc injury is lumbar flexion and lumbar rotation. A good indication for all indications are good, right? An indication for a muscle strain is if there's inflammation, we're not going to exercise that muscle, and then we're eventually going to progress to flexion stretching and extension strengthening. And then a contraindication for a muscle strain would be if during inflammation, we're moving that muscle and we're further aggravating it. An indication for spondylolysis and spondylolisthesis would be a squat, a shoulder press, and a push press, and a contraindication for those things would be a needed chest stretch, abdominal stretch, and pelvic neutral stabilizers. So we're going to talk about the shoulder. Some things that can happen with the shoulder is impingement syndrome. So that's the pinching of the supraspinatus, pinching of the long head of the biceps tendon, or the subacromial bursa. So we get to see that, I think, in the next slide. We can have anterior instability. So that's the front of the shoulder. The head of the humerus moves too far forward, and that can lead to dislocation. And we just want to remember that after someone dislocates their shoulder, they're more likely to do it again. And then we have a rotator cuff repair. So that's the most common tear, and it will involve the supraspinatus. It's repaired by sutures or sutures anchored to the bone, and then it causes an increase in immobility. So this is a neat little picture. I think it's really clean, so it's easy to look at. You can see the little bursa, you can see the tendon, the long head, the bicep tendon. So take a peek at this so we can orient ourselves. So our goals, if someone has a shoulder injury, I really love this picture because it makes the weird 90-degree safe zone totally make sense. So if someone has an impingement or rotator cuff pathology, we want to strengthen the rotator cuff and provide them pain-free exercises, of course. If someone has instability, we're again going to strengthen the rotator cuff, and then we're going to focus on scapular strengthening and stabilization. So we want to keep our clients with shoulder injuries in the safe zone. Now that you know that is your duty. So the safe zone is keeping their arms, their extremities neutral below 90 degrees of elevation. And then again, the picture shows you exactly what that means. So there's tons of, let's talk about this first. So shoulder injuries, these are conditions requiring shoulder exercise modifications, and all these conditions are listed below. Let's start with the first one, which is rotator cuff repair, rotator cuff tendinitis, glenohumeral joint instability, so someone dislocated their shoulder or had a subluxation, an AC injury or separation, glenohumeral joint osteoarthritis. And in your book, if you look at chapter 1, figures 21.5 to 21.9, there's some exercises that are depicted really well for these shoulder injuries. So we have to remember that exercise for anybody with those conditions is not contraindicated, but each condition requires specific modifications. So if you peek at those two pictures on the slide, those are exercises as well, but go back to the figures. This picture is mainly saying, while we're having our client who's in recovery or who has unstable shoulders, while we're working with them, make sure that you anchor them and that they have stability while performing the exercise, just so that they're safe and can really focus not on stabilizing, but on the actual muscle being worked. So these are some examples that you can do with your client. We're just going to go over a few, but I do want you to look through them all. That first one that we had, what am I talking about? That last picture that we saw is that first bullet point. So scapular retraction, that would be prone, right, on his belly. And then we have seated high row. That's a couple bullets down, but that's that picture that we have to the right. We have that machine at the rec too, I believe. I know we do. And then bent over flies or bent over row, standing high row. So these are going to be really helpful for your client. So we're going to talk about ankle injuries, and let's get right in. So it doesn't account for too many injuries for athletes, 10 to 28%. A lateral sprain is going to be the most common. And then we're going to progress these clients from non-weight bearing to weight bearing activities. And we got to incorporate strength training, range of motion, and balance. Wow, that was it for ankle injuries. Okie dokie. So we're going on to the knee injuries. So this is similar to the shoulder. There are so many injuries that can exist, but we're going to discuss anterior knee pain, ACL injury, and TKA, which is total knee arthroplasty. Okay, so anterior knee pain can also be called patellofemoral pain syndrome, PFPS, and that's a clinical term for general knee pain. Anterior knee pain is caused by overuse, overload, biomechanical faults, and muscular imbalance, and we just want to reduce inflammation and pain. So the ACL, the anterior cruciate ligament, I know it sounds like a lot, but anterior is just a ligament in the front, or crosses the front. There's a picture a couple slides back, or that last slide. The ACL is a primary stabilizer with pivoting and landing task, and it's going to limit anterior tibial translation and rotation relative to the femur. So it kind of keeps that tibia in check, doesn't let it go everywhere. And then emphasis, we would want it to be on strength, balance, and some plyos. With the TKA, that's a total knee replacement, total knee arthroplasty. That's the degeneration and degradation of the joint surfaces of the knee joint, and we're going to emphasize on range of motion, along with strengthening those hips and quads. Some goals that we have for these injuries, remember that the goals are the indications as well. So with an anterior knee pain client, we can allow them to do a fourth or a half squat or leg press, a partial lunge, or a leg curl. Remember, we're going to reduce inflammation and pain. Contraindication for anterior knee pain is a full squat and a full lunge and going to the end range of extension. For ACL, same thing, a 3/4 squats or similar thing, and a 3/4 leg press, a step up and a stiff leg deadlift or a leg curl would be great. And then something we would not want to do if someone is recovering from ACL is going to the end range of leg extension or open chain exercises above 45 degrees of knee flexion. With that total knee replacement, similar to anterior knee pain, they can do a fourth to a half squat or leg press. Again, a partial lunge, leg extension, leg curl, fair game, stationary bike, aquatics, awesome. And then contraindication would be full squat and full lunge for total knee replacement. Let's talk about some hip injuries. So we have some basic goals, not basic goals, but clearly outlined goals. We can introduce the pull. We're going to introduce some balance and proprioception exercises. And then we're just going to make sure that we listen to the healthcare provider's limitations. Arthritis is sometimes autoimmune. So autoimmune arthritis is rheumatoid arthritis. That's inflammatory disease affecting people's joints, and it'll affect the joint's synovial lining. And then osteoarthritis is a deterioration of the surfaces of the joints. So just remember, one is autoimmune and one is over time deteriorating. We can add strength training to anybody who has arthritis, but let's look at the indications and contraindications. So some great things would be biking, swimming, open kinetic chain exercises, and then making modifications for those special areas like wrists, shoulders, and their spine. Some things we want to avoid is high impact activities, so constantly banging on the joints like running, skiing, jumping. We want to avoid that joint pain. So that's the end of the slide. Hopefully it wasn't too fast or too slow. Hopefully you got something good out of it. And remember that this is just to complement reading chapter 1 and kind of highlight and pinpoint the most important parts of the chapter. So please leave any questions that you have in the comments. Like and subscribe. Just kidding. And I will see you guys in class.